I appreciate everybody coming out today. This is not supposed to be formal. I know the room doesn't really say that. I'm just going to try my best to share outcomes and treatments that were provided this year with men's basketball, golf, and some other teams throughout the year. And then hopefully talk to you about kind of why or how I think they worked or didn't work. And then open up for questions at the end, as well as discussions as far as how we can do patient care better throughout the next year. Going forward, use the mic too. Yeah. Hello? Hello? Hello. Perfect. Okay. Clinical practice and patient outcomes, learning from the care provided. Okay, everything we have here is approved through the IRB. We have to go through that to make sure that anything that we collect from patients is de-identified, meaning it doesn't have any names or anything on there. There's a few videos that we have in here because they can like see the changes real quick. It's kind of fun. But those have little blue dots on people's heads, so you don't know who they are. Just so you know. Main purposes. I'd like to show immediate results that have occurred throughout the year, as well as tracking outcomes over time and how we're doing that. And then demonstrating examples of patient care from a clinician scholar, meaning someone who is well-versed in the research and then also providing clinical care. Personalized medicine. Personalized medicine is the idea of treating every single patient as an individual. Through research, a lot of times we look at a larger group of people, and then we try to say, okay, that's going to work with this group or not work with this group and generalize it. But a lot of times we miss out on that one patient, and we're working with that one patient. So if you have a 6-foot-tall women's basketball player, and you're going off of research based on 5'8" men cross-country runners, it gets really tricky. But there's not enough research out there to make those decisions because we don't have 700 studies on 6-foot-tall women's basketball players because there's not that many. Right, Lindsay? There's like a few sticks. Patient-oriented evidence is one of the main things that this talk is going to touch on, and that's gathering information based on what the patient feels is occurring. How do they feel they're getting better or getting worse or staying the same? Along with the disease-oriented outcomes, which are range of motion, strength, other types of functional tests that we do as well already as athletic trainers. And then putting those together to triangulate, it's a key word, the best care for each individual patient. Theories of rehabilitation and theories that I've used and most athletic trainers use while they're treating patients. We have the closest one, the Elwood, that inside one. That's going to be your individualized treatment. That's when you're getting all the way down to that individual person. A lot of times we start with a pathoanatomical approach. That's the bottom one. And that's where we're treating someone based on the anatomy and how their body should be working biomechanically, anatomically. And that's a great way to start. Then after that, you get into the neurological breakdown of someone. And maybe their function is not appropriate because their nerves are not functioning appropriately. So maybe we need to treat from a neurological standpoint. And then the next one, which I think we do a really good job here with SAE, is where we get into the psychological component. And I think that's where the mental wellness is, and then you get into biopsychosocial components as well as bioenergetics, which is some of the different techniques that I've used this semester. And I'll get to talk to you about all of those. But when we're not using all of these together and all the other ones that are out there, there's multiple ways to treat patients, and we're sticking specifically to a pathoanatomical, that's when I found that I've been less successful. So I'm trying to open us up to using multiple techniques, and that's what I'm trying to do with myself. List of all interventions used. I'm not going to break down each one of these, but at some point throughout my career here, I would like to have workshops where we get to go over these different ones. And I think it's just another option, again, giving people more tools in their toolbox. This is how I broke down the treatments that I provided throughout this year. So we have a big pie graph and a little pie graph. The big one is going to include more pathoanatomical approaches, right, such as ultrasound, electrical stimulation, soft tissue mobilization, instrument-assisted soft tissue mobilization, therapeutic exercise, and that makes up a small portion, 14%, and then the others are those techniques I just showed you. interventions I just showed you. So most of the time, 86% of the time, I was using these other techniques that maybe are not based on a pathoanatomical approach. And I think the more we can spread out how we're treating and different ways we're treating people, the better or more successful. All right, outcomes. How do you know if any of these techniques are being effective, right? So people returning to play, that's huge. People not missing practice, that's a big one. But then also quality of life, perceived function, thought processes of how well they want to be moving versus where they are at that current time. And that's what all these different outcomes that I have actually laying up here on the chairs, we can look at those after if you want, are measuring, or different ways to measure those. Discharge criteria. I'm going to touch on discharge multiple times throughout this presentation. That's when we're saying someone is able to return to full activity, unrestricted. They're not coming into the athletic training clinic anymore for that specific issue. Maybe they're doing preventative things after then, but you come in for an ankle sprain, you get treated 4 times, and then you are discharged and you return to full activity. That type of thing. Basic ideas for discharge are full range of motion, full strength, decreases in pain, full functional activities during movement, as well as a lower than 23 score on the Disablement Physical Activity Scale, which is one of the scales that I'm going to share with you. A patient-specific functional scale is looking at someone's perceived function. You want to make sure that they're at least thinking that they're at an 80% or an 80 or above. So I think once you add all of these things in, again, you're triangulating patient care to that individual patient to hopefully put them in the most successful position as they return to sport or physical activity. Time loss activity. This is men's basketball. Time loss last year, right, this season. So these are games that were missed. Okay, thanks, Juan. ACL rupture, number 1. And then we have concussion. We have hernia surgeries. We have lateral ankle sprains. We have hip flexor strains. We have other things like that. The main thing that I take away from this is that these are all acute injuries, right? So that's pretty good, I think, right? We don't want to have a lot of chronic or persistent issues that people are missing time for because they just can't really get going. They can't really get all the way. But then also, how are we measuring that? Do we know when they're kind of dealing with something and it's limiting them and they're not really fully functional but they're still playing? And that's where I think the patient-oriented outcomes can help us with those measurements and getting people even closer to 100%. I highlighted the hernia surgery and the hand fracture because those were non-basketball related, so I think it's fair to consider those as being outside injuries. Have it in the fun time. Preventative techniques. This is for CJ and myself with golf. CJ did a great job with a stretching technique in this last semester for hamstring flexibility. I have some data on that. We also use the total motion release system, which is based on 6 different movements, finding the functional movement that is most out of balance, and then trying to work on the one that feels the best to put it back in balance. And then there's a whole bunch of like neurophysiological changes that occur in neural coupling and all these other things. This is messy. This is the most messy one I have. Sorry. Yellow on this side means that they had a difference of greater than 15% in their internal external rotation of their hips. Okay? Some of the research says that if you have greater than 15% difference, then you are at a higher risk for injury. After one session of TMR, we had the greens means that they became within that 15%. Okay? And the yellow means they stayed the same in the second category, right? And the red means they increased. So some people that went through the stretching protocol that we set up, which was, this is all one session, right? This is immediate change. They did one of these, this one, one of these, right? And then for the TMR, they did something like, okay, which one feels better? Not that one. And then they did this one. And then that released their hips, right? And it's kind of cool when you're getting into the ideas of how the different fascial systems work and all of our body works together. And I think that's what that's kind of showing. And again, this was immediate change, so I'm not saying this is going to change people forever, but if you can make immediate change, sometimes that's super important to someone. Hamstring range of motion. Again, this is what CJ put together a stretching program for the men's golf team, and they would do this after every session. We have the people that, I then took that and went a little bit further, and next step, I added TMR for 3 of those patients, or participants, student athletes. And then for the other 4, they completed simply the stretching, or the stretching, which was good, as you can see. The green is an increase in range of motion for straight leg raise. So they're laying on a table, and they lift their leg straight up, okay? And that's what the measurements are there. The first 2 columns are before treatment, before the 7-week protocol, and then post, and then you can see their perceived function is the next column over, okay? And again, you can see the green increases. So stretch, right, the top stretch one, we had an increase that was greater than 2, which means they perceive that they improved their flexibility by greater than 20%, which is a minimal clinical important difference. So it happened with stretching, which is great, right? But it also happened with TMR. And it happened with TMR in multiple categories, right? And all we did was add it. So it's not like the stretching didn't help. The stretching definitely helped. But we can add another thing, right? And then we compare with a group that stretched only and a group that stretched into TMR. And this is the closest I can do to doing research in the middle of our season and stuff. But I think it's still meaningful stuff for one team, right? This doesn't mean it's going to work for everybody, but it's something that we can then consider. Specific classifications for men's basketball, women's, and men's golf this year. Hamstring strains, lateral ankle sprains, low back pain, post-ACL, subacute torticollis when you have like a neck, feel like a crink in your neck, that type of stuff. Yes. Upper back tightness. Jones fractures, we had 3 people who had Jones fractures throughout over the past 2 years. So that's something that I think is worth looking at. So I looked at that and I put that on there. Tracking change over time. For 3 different patients who had fractures to their 5th metatarsal, the outside bone in my foot, we had an acute individual who had surgery, and then we tracked him from moment of surgery on. We had subacute who had surgery, and we didn't see him until like a month or 2 weeks, 2 months after the surgery. And then also someone who was persistent, who had returned to participation, but still was having kind of lingering issues. They were treated with soft tissue mobilization, MYK, which is a neurological treatment based on the nerve root of the body and stimulating different sensations or parts of the body during movement. And then energy medicine, where we were treating based on bioenergetic fields and different things like that. But anyway, those three together, these are our changes on the DPAS scale. So this is their perceived dysfunction based on pain, muscular function, stability, control, balance, all of those fun things. And then we have the bottom category is well-being or quality of life. I think you can kind of see this, but if you look at September to October to January with this acute patient, you can see the numbers get closer to the 0 side or the left side, right? And there we are tracking disablement over time. That's all we did. Yep. And then the next one, subacute, same thing. You can see decreases or closer to zeros in all the categories from September to January. So you can then say that over time, this patient improved their ability to be functional as a patient or a student athlete, physical active individual. And the last one is the persistent individual. This person didn't have as much change to make, but he still made it. And that's all important. The different time points are beginning of the season, end of the season, and the middle of the season, right? January's about the middle of the season. So I think tracking things throughout time is super important to know if we're making change like we're saying we're doing in patients. All right, immediate change in low back function. So a patient with low back pain comes in, hey, my back hurts. I don't know what I did. I kind of know what I did. We diagnose them as a strain, a sprain, something along those lines, but they have low back pain. We had immediate changes in pain, the numeric pain rating scale, the NRS, of a 4, right? So it's a scale from 0 to 10, where 10 is the most pain and 0 is no pain. And in these 7 patients, they all had decreases in pain, and the average was 4 points on that scale. So therefore, they are decreasing pain. 2 is a minimal clinically important difference change. The MSFS is the multi-segmental forward flexion score. So you have them in, and they go like this, they go, ah. And then for these people, we treated with RNS, or a reflective neuromuscular stabilization technique. And all we did was like push them like they were the Pillsbury Doughboy, and they would react, and then they would go down. And then we measured their change, and also evaluated their pain. And just changing their movement pattern changed their pain, and it changed their function. And again, these are immediate results. Sometimes they came in, 3 or 4 days later, and they were not better. So that means that maybe it was not the best treatment for them. But at least immediately, you're able to see that you can make a change in someone, and that's, I think that's meaningful. That's helpful to know or think about, like how changes are happening in the human body. I got like a few more of these. Sorry. Primal reflex release technique, or PERT. These were based on scores that I did at the last school I was at. I just wanted to put them in because I presented these at the National Athletic Training Association last year. So I thought it was meaningful to share with you. But same story. We have pain, we have disablement in physical activity, we have functional or perceived function, and then we have the classification of a grade 1 hamstring strain with manual muscle testing completed, as well as an active knee extension test. So their ability to straighten their knee in a flex position. So they're laying on a table like this, and then they go like that. A lot of times with stretching, there's great protocols out there for eccentric exercise, for hamstring strains. There's great protocols for eccentric exercise, for stretching, for neuromuscular activation. For these, I tap these people in the legs and in the hips, just like tap them at that karate chop. And we changed how they moved and how they felt and all that stuff. Had a 1 week follow-up and then a 6 week follow-up. So I think that's, again, it just shows that there's other ways to do these techniques. This was probably based more on a neurophysiological change, restoring reflexes and how their body wanted to react to movements, and also understanding that they were hurt or not hurt. Case studies. These are specific to individuals. This is where we get fun stuff, and we get some videos in here. Syndesmotic ankle sprain or a high ankle sprain. Individuals treated with mulligan concept. So we're moving bones, trying to correct a positional fault, so it's a joint treatment. Then they're moving through a motion, so that part is a repatterning of their neurological movement patterns. And this one is really hard to see because I collected a lot of outcomes on this person. But I'm going to try to present this in a journal as well, so I think it's fair to share with you. But over time, you can kind of see we have changes in pain, that's the top part, changes in dysfunction, specific functional measures. So we asked the patient, walking, do you have issues? Running, squatting, jumping, and single leg stance, and each one of those improved. We also measured with the foot and ankle ability measurement, which is asking specific questions about squatting, walking upstairs, jumping, running, jogging, cutting, sport-specific things. So again, we're just getting even more detail. We're getting more information about how we can help these patients better. I guess more details. Also had the Y-balance test. We also did the SFMA, which is a functional test. Gleigers, as well as anterior subtalar glide test. So we're not only basing it on their perceived function, right? That's not fair. You can't just do that. But we're not only basing it on the function that they're showing us as well. So it's not just what I see, it's what they see, and then it's a combination of both. Okay, now we have some videos. Okay, so that's the leg that's not hurt. Not hurt, right? You see where that one went? Okay. And then we have ouch leg. Okay. So did anyone see the difference? Okay, good. Just make sure. And then we have this individual did 3 sets 5, lifted their left leg. Right? We had to mess around until we got to that. But that was the one that felt the best and felt the best for the right leg. How does that work? I don't know. That's why I'm researching all this stuff. But does that mean that maybe we started to fire this side, which then released hip muscles, piriformis? Are we getting into multifidus on this side? Are we starting to change balance and proprioceptive awareness? I don't know all that stuff, but this is at least showing effectiveness in the clinical setting. So that's in one treatment, and I think that's kind of cool to see. Again, we got a hip flexor strain. This was an individual who missed time, right? So we probably grade this a grade 2 hip flexor strain based on discoloration, swelling, all that stuff. So that's pathoanatomical. You have to treat that part pathoanatomically. You don't have to, but you can. There's also other parts such as breakdowns in your neural movement patterns, your understanding of that space of your body anymore, the change in sensation, and all of those things. This individual, again, this is too much stuff, sorry. But we have pain, we have, again, function. We did walking, running, squatting, jumping, single leg squat. One of the other ones on here is the GROC, and that's global rating of change. So we're just asking them pre and post treatment if they felt better or improved, and you get a number to score it on. So it's just another way of documentation that you're actually making a change, which is what athletic trainers do. And the more we document it, the more we can say what athletic trainers actually do. But this patient started with a -2 and worked his way up to a 7 on a 7 scale. So he felt that he got better, right? That's what that says. That's how it works. Here we go. Shoulder dislocation. MRI to rule out labral injury, as well as to rule out Hill-Sachs lesion, which is one of the things that we were thinking about. But we have pre-post for this individual. This is only the involved side. Flexion and adduction. Flexion is forward, adduction is out to the side. First one. Okay, it has movement, right? So that's good. So his nerves are working, but maybe they're not firing 100% the best, and that's why he can't get to where his normal motion most likely is, which is probably 170 to 180 degrees up here. Okay, then we have adduction. This is going up to your side. More limited, or limited at this time. Is that because it hit a nerve? Is that because we messed up the joint? Is that because all that stuff? Probably. Is there also fear avoidance now, that he's afraid to move into those positions because I just dislocated something, I don't want to like have it fall off my body again? Right? That's like what it is, that's scary. This is post-treatment, right? So this one, I like just flicked his eyes, pulled on the back of his head, tapped on his neck, and all we were trying to do was down-regulate his neurological system. I didn't think there was a great change in that one, right? I don't think he changed that one much in that one. Also, here, not a lot changed. I mean, maybe 20 degrees, there wasn't a whole bunch. But we didn't do anything as far as stretching. I didn't hurt him, and he still got better. Then the next day, he came in, and this is where I was for flexion. So time improvements over time, right? He made changes. That's not only him healing, feeling better, but also we did one treatment. Going to the side, still not very good. Okay. Then we did that same treatment again. Treated his neurological system, tried to calm down his body, tried to make his reflexes react at a normal reaction rate instead of overreacting to movement and sensations. I think that one is a more pronounced change the second day, so maybe we did the treatment better, right? That's a possibility as well. And again, same thing, we had changes. This is again, just 2 treatments, no stretching, no pathoanatomical changes, simply based on his neurological system and how we affected that. I think that kind of stuff is interesting. KOOS score. We have the knee injury and osteoarthritis outcome score. So over time, we're looking at an individual who tore their ACL and measuring their changes from post-surgery, where they had a higher KOOS score, they were more dysfunctional, they had more issues, and then we're at 4 months now, and we're at 18. So he is improving his ability to move and function with his knee, both knees. All right, and then the last few ones here. Okay. Patients, we got acute, subacute, and persistent issues. So acute means that just happened. Subacute happened like 2 or 3 weeks ago, up to a month, maybe 2 months. And persistent is it's been going on for like my whole life. I don't remember the last time I wasn't like this except for when I was in the womb. And then you like question it on that. It's But anyway, we have function, right? So we have an initial score and then to a discharge score. We have percent change, right? That's going to be pretty meaningful. If you can tell somebody when they come into the clinic that you can change their function by 40, 50, 60%, do you think that they're going to want to be treated by you or with you? Most likely. If we can do that as a whole staff, which I think we can, which we do already, right? We do that. We can then, show patients that they will get better as soon as they walk in, and then you change the whole mentality of getting better, going to the clinic, all that stuff. But you can see here the reds are people or specific populations that I did not change at a level that I'm happy with, right? I want to be better at improving immediate function changes in patients with subacute conditions and persistent, right? Because 20 and 13% is not, I don't think that's very helpful to people. But I wouldn't know that unless I'm tracking that stuff. So now I tracked it, now I know, and then I can try to change it. This is just a graph, so it makes sense of all those words I have over there. Pain science, this is a big one. I was able to do a discussion on this with some student athletes earlier in the year. I really appreciate the opportunity to do that. I think pain science is super important. Dr. Mr. Mike Cerrito, has already talked about how some physical therapists, athletic trainers are using simply cognitive therapy to re-educate and undo education about pain so people can understand maybe, hey, I can get better. Hey, it's possible to change my discomfort and my pain with simple thought processes. And these are some of the things that we're doing in the clinic right now. We have cognitive therapy, which leads to having knowledge is power. Neurophysiological knowledge of pain, like how does pain actually work and where does it go, and is my knee actually hurting or is my brain hurting because my knee thinks it hurts, right? And that's really great. From the gait theory to the neural matrix of pain, which is where I think we're going next, and I'm going to share that in my own time. Here's a lot of noise. That's this one. That's the neural matrix of pain. And that's a circle that's got half circles and partial circles in it. So it's kind of confusing, right? So how many times we try to explain that to a patient versus the gait, where there's painful stimulus that comes up, but when you do this, then it doesn't hurt anymore. So that's one way to explain it, but there are multiple ways to explain pain. And then you can also get into your awareness, where you are, past histories and painful beliefs in the past, and also in others. I think all those things need to be considered when we're talking to patients. Painful outcomes, there you go. They had more pain. Immediately post, they had less pain. And then at discharge, they had almost no pain or less than 2, which was what I based my discharge criteria on as well. Okay, mental health and wellness. Treating function while tracking wellness and well-being. Sleep quality and quality of life. We were really fortunate to have a sleep presentation that was done this semester with student athletes. During that time, I was able to take information down about people's perceived sleeping patterns. And then I put it on a screen. So Pittsburgh Sleep Quality Index Scale. It's one of the ones that's up here. It's one of the outcomes that we have over here. We're measuring a patient's sleep quality, okay? So anything above 5 means that patients are not sleeping well. They're having issues when they're trying to sleep, right? These are all student athletes that we had come to this discussion. As you can see, the mean is 6, okay? So that means that the average, or the majority of these 35 patients, student athletes, had issues with sleeping based on this scale. So what happens if we started to try to treat that with some type of sensory flow or cognitive therapy or stuff that we're already doing, and then we could measure if it's actually making a difference by providing this outcome scale. That's all that is. Quality of life on the DPAS scale, we have increased uncertainty, stress, pressure, anxiety, altered relationships with teams, friends, and colleagues, decreased overall energy, changes in mood, and increased frustration. These questions are on that scale that we're providing to patients. When we see that they have a high score on this, that might be an opportunity to refer to Mike Cerrito. It might be an opportunity to try different treatments that are directed at the biopsychosocial aspects of their injury instead of strictly or only the pathoanatomical approach. Here's 15 patients that had persistent conditions. These are conditions that they felt they had for long periods of time. Out of those 4 questions, right, the max score would have been 16. So 6.5 is not that bad, but it's still high, right? A lot of people had zeros, had 1 or 2 in those categories. But these people had an average of 2, right, or almost 1 point something. Not good at that. But the follow-up, which was a month or 2 months later, because I treated these people over a long period of time, their quality of life disablement decreased, meaning they had a better quality of life. Discharge, 1.8. So again, we saw decreases in their disablement of physical activity, quality of life scale, meaning they're improving their quality of life. It's something to track. It helps us understand where people are and how they're doing. I think it ties us into all the mental health and mental wellness things that we're working on here, and I'm really happy to be a part of it. In the future, maybe we start tracking selective functional movement screen with the sleep quality scale and a resiliency score, which is based on your understanding of how well I'm able to adapt to change. A trip score, which we have for some sports because we have the heart rate monitors and systems. The wellness score, which we're already doing as an SAE group. And then maybe we get more strength measurements or some range of motion in there, and we can help detect or recognize injury patterns as they occur so that we could then maybe help decrease them in other patients before they happen. This is one of the things that I think field hockey is very interested in, and they've already talked about looking at doing this. But I think all of our sports can do this. I don't think it needs to be mandatory, right? Clinicians still need to make decisions that work the best for them, but this can be something that we add to what we do. And then why did I do this and why did I talk to you about all this stuff? Because I like to talk to you. And then also, understanding patterns and variability will allow us to develop new and more effective interventions, matching patients with current intervention. So when I have a patient come in and they have this, this, and this, and they're complaining of this and this, I can then say, okay, I know that stretching is the best for you. And then if this, this, and this, this, and this, right, and maybe they have a biopsychosocial issue, I know that we need to downregulate your nervous system. So this type of treatment would be really good. And then we can start like grouping patients individually, right, instead of basing it on research that's been done on people that we don't even know, right? And that's kind of the hope for all this stuff. There is a way to do it better, now find it. That's from Thomas Edison. That's how I started my doctoral program. When I thought about going to it, I thought I should try to do something better. I should try to get better every day. And that's a great quote because that's what he did, right? He spent like 100,000 times looking at light bulbs. Maybe not 100,000, maybe just 1,000. Okay, legislative meaningfulness, last few things, and I'm just going to thank you a lot. When I went to the presentation discussion with legislators from the United States of America, I got to talk to the legislative assistant for Tim Kaine, and one of the things that the Virginia Athletic Training Association president talked about was the idea of decreases of pain immediately by up to 70%, and he talked about that, and talked about what we were doing here at Longwood with decreasing pain immediately. And she thought it was pretty cool, and she's going to share it with the senator. So we're like that's the type of change you can make for athletic training and also for every single patient that you work with. References, it's a lot of stuff that you can't read, and if you want these, I can send you these. This is, I think, super meaningful too. We've shared this through social media with the Virginia Athletic Training Association. But Dr. Deck was nice enough to give an AT shout out where she expressed how she feels about athletic trainers and what they do. And I think this expresses our value. And that's all I'm trying to do, is share our value not only from what other physicians and other providers think of us, but also from what patients think of us and what they think about how they're getting better. I think the more you have, and you triangulate your patient care, you triangulate your value, and you really can make a difference in the profession and also how we provide care to patients. Thank you to the University of Idaho doctoral program, the faculty, which I just consider like a big plane of people, and then all those fun people in that picture there. I'm at the end. And then de-identified patients, you know who you are, and SAE. So that's the picture we have on the website, so if you don't like that, it's on the website. And then I really would like to talk if you want to, and if you don't want to, I get it. But if you want to talk after, we can do that too. And again, I got all this stuff up here, so we go about it. Any questions right now on things that were touched on or ideas? Oh yeah, in the back.
No, I'm good. I'm good.
Right. Did I make it? Perfect. Well, then, thank you very much. Thanks for coming.